Vaishnav. So earlier we have discussed about myopathies which are secondary myopathies. Secondary myopathies means muscle involvement secondary to endocrine, metabolic, toxic, infective, myoneural junction, and all those things. Now we are going to talk about primary myopathies. These are very important for you for theory as well as for the patient care. Okay. Primary myopathies are also called the muscular dystrophies. Okay. So how to clinically think of a muscular dystrophy? When should I think of muscular dystrophy in a patient? Number one, it should be chronic and slowly progressive muscle weakness. So if the weakness is chronic, if the weakness is slowly progressive, then you must consider. Second one is proximal muscles, like the gluteal muscles and the shoulder muscles are more affected than the distal muscles. Limb girdle pattern and absence of sensory loss. There is no sensory loss. Preserved reflexes very much early, late because of muscle involvement, severe involvement, reflexes may be lost. CK is often chronically elevated. There will be family history of myopathy, but patient can occur without family history also. Now, what are the pointers, Vinay?
Chronic long-standing weakness, slowly progressive weakness, proximal more than distal.
No sensory loss. Breathe, and then probably reflexes are preserved, and elevated CPK is elevated. Maybe family history may be there. No, what is the common language used in the exam by the examiners? Limb girdle muscular dystrophy, LGMD, Becker's muscular dystrophy, Duchenne's muscular dystrophy, sacroglycanopathies. These are the four different terminologies are used. Limb girdle, there are four types: LGMD, Becker, Duchenne, sacroglycanopathy. Facioscapulohumeral, which is called the FSHD, facioscapulohumeral disease. Distal myopathy, distal weakness, myotonia, where myotonic dystrophy, and early contractures are a feature of Emery-Dreifuss syndrome. Emery starts with E, early contractures are a feature of that. Early contractures, Emery-Dreifuss. Cough hypertrophy, if you see exclusive cough hypertrophy alone, dystrophinopathies are possible. I used to have a patient who is around 40-45 years. His only complaint was no weakness of the muscles, but both the calf muscles are much bulkier than normally they appear for that age and gender. Then when we investigated, it is one of the dystrophic, muscular dystrophy. Okay, it may not present with weak. Now, what are the types you tell? Limb girdle type of muscular weakness, facioscapulohumeral, distal weakness, myotonia, early contractures, in Emery-Dreifuss, and then cough hypertrophy. Under the limb girdle, we have got LGMD, that is Becker's, and then the Duchenne and sacroglycanopathies. So we wanted to look at dystrophies, muscular dystrophies, also called dystrophinopathies. The forerunner, most important hallmark of muscular dystrophy is Duchenne's type of muscular dystrophy, also called the DMD, Duchenne muscular dystrophy. Most of them are genetic syndromes. This one is X-linked recessive. Duchenne is an X-linked recessive mutation in the dystrophin gene XP21. Okay, usually frame shift will be there, nonsense mutations may be there may be absence of dystrophin. Okay, and then around 2 to 5 years, onset is very early in age. 2 to 5 years age, clinical presentation, very early symptoms, patient report, delayed motor milestones, child runs very slowly, frequent falls will be there, difficulty in getting up from the floor, difficulty in climbing stairs, and waddling gait. So, The classical features of dystonia are X-linked recessive, mutation in the dystrophin gene XP21, early onset, 2 to 5 years of age, delayed motor milestones, child runs very slowly compared to the peers, frequent falls will be there, difficulty in getting up from the floor like a normal child, and that is called Gower's sign. We'll see it later. Difficulty in climbing the stairs and waddling gait. And second, the classical pattern of weakness. What is the pattern of weakness? Hip extensors and abductors are very much affected early in the disease. Gluteal weakness, hip extensors and hip abductors are the gluteal. Gluteal weakness will be there, quadriceps weakness may be there, shoulder girdle may be there, neck flexor weakness may also appear. Hence, proximal limb girdle distribution. What are the classical bedside signs? Child raises from the floor by rolling onto the prone position, then using the hands to climb up the thighs. This is called the Gower's sign. So if you ask the child to sit on the floor and lie down and get up, child instead of the supine position will not be able to stand directly. Child rolls onto one side to the prone position, then comes on the forelimbs and then comes onto the knees, then slowly lifts the forelimbs and the hands and puts them on the knee joint and the thigh to slowly get up and support. This is called the Gower's sign. You would have seen. Did you ever see a Gower's sign? No, not seen. Seen. You have seen? Okay. A reflection. What does it reflect? It reflects extensor weakness of the hip, proximal lower limb muscle weakness. So this will be asked. Gower's sign. Which muscles do you think are weak? Extensors, so the hip joint, proximal lower limb muscles are weak. Then waddling gait. What is waddling gait? You have ever seen the duck walking? Duck and this one like that only. Waddling gait. Due to pelvic girdle weakness. Positive Trendelenburg test. What is positive Trendelenburg test? No.
There will be one leg will be due to the opposite pelvic shift will be there to one side.
Demonstrate Trendelenburg test.
So there is weakness on the right side. They will be shifted towards the opposite side.
How do you do the test? That's not Trendelenburg test. How to elicit Trendelenburg?
There will be drift while walking.
Stand. I'll tell you. Stand like that. Turn towards me, and then you try to stand on one foot. You can hold the patient can hold the wall. There's no problem. It's not about balance. So patient can hold wall or something, and go a little nearer. Try to hold this. Lift one foot at 90 degrees at the hip, 90 degrees at the knee. Okay. This normally 30 seconds you should be able to stand like that. Any person. Okay. In this patient, because of the proximal muscle weakness, because of the limb weakness, then the affected side pelvis is shifted to the others. It is tilted up. Okay. This is called the Trendelenburg test. Phones later. Not now. No phones in the club. Due to the pelvic girdle weakness, positive Trendelenburg. It will be asked, do a Trendelenburg test. How do you do if you are talking on the phone? You must understand what is Trendelenburg test. I have already demonstrated it. Okay? So you get from them. Or you read thoroughly about Trendelenburg test. Cough pseudo-dystrophy will be there. Pseudo-hypertrophy. What is pseudo-hypertrophy? Text it. Whatever you have, I am in a class. I will not be able to call you. Please text me. Okay, called pseudo-hypertrophy, enlarged coughs due to fat infiltration and fibrosis. Why it is called pseudo-hypertrophy? There is no true muscle and muscle hypertrophy. It is more of fat and fibrous tissue. And if it is true hypertrophy, muscle will be strong. Who will have true hypertrophy? Who will have true hypertrophy? Athletes, people who are doing bodybuilding, they have true hypertrophy. They have muscle power. Here, this is a infiltration of fat and then fibrosis and not muscle hypertrophy. So weakness is a feature. Lumbar lordosis will be there. Why it is a lumbar lordosis? Because of the extensor weakness. See, the extensors of the hip are not able to keep the hip straight in the extended position. So much so the lumbar lordosis will be there. Toe walking, often due to Achilles tendon tightness. The Achilles tendon is very tight. What is the purpose of the Achilles tendon? Achilles tendon, what does it do? Plantar flexion. So if the Achilles tendon is very tight, then he cannot dorsiflex it. So he will be on the toes, toe walking. So these are very important features. Okay. Number one, Gower sign, which you already know, waddling gait, and Trendelenburg is positive. Calf pseudohypertrophy will be there. Lumbar lordosis will be there because of compensation due to hip extensor weakness. Toe walking because of the Achilles tendon tightness. Because of Achilles tendon is not released, dorsiflexion is not occurring. He cannot plant the foot completely on the ground. He keeps the toes in contact with the ground and starts walking. So now I am describing Dystrophy again. A child around 2 to 5 years age comes, progressive muscular weakness, not able to walk run normally, not able to climb the stairs. If you ask the child to get up from the floor, there will be a test, Gower sign will be positive. Hip extensor weakness is there. Lower limb proximal muscles are weakness is there. Waddling gait due to the pelvic girdle weakness, positive Trendelenburg, pseudohypertrophy, fat infiltration, fibrosis, lumbar lordosis as a compensation, toe walking because of the Achilles tendon tightness. So the patient, father and mother will immediately ask her, sir, what will happen to my child? That is very important. Child will be bound to the wheelchair typically in a decade. By around 12 years, child will not be able to walk at all. So it's a very miserable condition. Upper limb function also slowly declines. Progressive scoliosis may be there, contractures of the Achilles, hip and knees, elbows and wrists later. Most important thing is for UPs is when you look at the Duchenne's dystrophy, you must look for respiratory and cardiac involvement. Systemic manifestations, dilated cardiomyopathy is a feature. Vice versa also. If a young child presents with dilated cardiomyopathy, you must look for Duchenne's muscular dystrophy. If you see Duchenne's, you must look for dilated cardiomyopathy. Arrhythmias may be there. See, initially may be asymptomatic. ECG, deep Q waves in the lateral leads. Why? What is the cause of deep Q waves?
It can be early or
septal hypertrophy. Septal hypertrophy. Dilated cardiomyopathy with septal hypertrophy. Conduction abnormalities. Because of the hypertrophy, the conduction bundles are there in the septum and conduction abnormalities will occur. Respiratory involvement, progressive respiratory muscle weakness, nocturnal hypoventilation, recurrent chest infections, lower respiratory failure. Neurocognitive features, mild intellectual disability, learning difficulties may be there, not inevitable, but may be usually associated. Now, what are my features? Muscle features. These are the muscle features, bedside sense, Gower sign, hip extensor weakness, waddling gait, Trendelenburg positive, calf pseudohypertrophy, lumbar lordosis, toe walking. Progression is very fast progressing. In a decade, child is bound to the wheelchair. Upper limbs may slowly affect. Contracture of the Achilles tendon and other hip and knees may be there. Systemic manifestations are important. Dilated cardiomyopathy, arrhythmias, ECG changes, respiratory environment, progressive respiratory muscular weakness, nocturnal hypoventilation, recurrent chest infections may be there, and lower lateral respiratory failure may set in. Then, neurocognitive features, mild intellectual disability, learning difficulties, key investigations. What should I do? Obviously, I should ask for CK. CK is markedly elevated, more than 10,000. And we have to do genetic testing. What is MLPA? Multiple ligation dependent probable probe amplification. Multiple ligation dependent probe amplification. Ligation probe amplification. Muscular biopsy or muscle biopsy, absent dystrophin in immunohistochemistry. So CK is markedly elevated. Genetic testing for MLPA has to be done. Muscle biopsy shows absent dystrophin in immunohistochemistry. ECG and echo are routinely done to look at the cardiac myope. Exam viva one-liner. A boy aged 3 to 5 years with proximal limb girdle weakness, Gowers and positive calf pseudohypertrophy, progressive loss of ambulation by early teens, he is not able to walk, suggests Duchenne's muscular dystrophy. Now, among the limb girdle, we have the second one, which is called the Becker's muscular dystrophy. All these are coming under the limb girdle type of muscular dystrophy. So we started where? So dystrophinopathies, and under the dystrophinopathies, we have got the limb girdle type. Under that, first Duchenne's we have seen. Then we have to see the Becker's type. What is this one? Duchenne is X-linked recessive. Whereas when you go to Becker, it is X-linked. It's also X-linked again. It can be codominant or it can be dominant. Dystrophin mutation may be there, and then onset is adolescence and adult. That is 12, 13, 14, 15, 20, like that. Not 2 to 3 years of age. Clinical difference from Duchenne dystrophy is similar distribution like Duchenne, proximal limb girdle, but slower than the Duchenne, slower progression. Ambulation is preserved even after 16 years. If you have a muscular dystrophy child who is able to walk after 16 years, you should not diagnose Duchenne, because by then they are wheelchair bound. And this is a slowly progressive disease. They are still able to walk. Calf hypertrophy may be present. Cardiomyopathies may be sometimes seen. And many patients first present is exertional dyspnea, arrhythmia, and cardiomyopathy, and not muscular weakness. Okay. So we have two classical types of things. Duchenne and Becker we have seen. And then comes the limb girdle type of Duchenne muscular dystrophy, DMD, and then the Becker's type of muscular dystrophy. This we have seen. Limb girdle muscular dystrophy is a separate entity. Becker and Duchenne we have seen. Sarcoglycopathins we will see. What is the LGMD? That is limb girdle type of muscular dystrophy. In the limb girdle muscular dystrophy, we have got clinical presentation, a group of muscular dystrophies characterized by both pelvic and shoulder. Limb girdle, that is both the pelvic and pectoral girdles, both the shoulder and pelvic girdles are affected. Variable inheritance, maybe autosomal dominant, maybe autosomal recessive, whereas the other two are X-linked diseases. How LMD presents clinically? Adolescents and young adults, 20, 25, that age group also they will come. Difficulty in running, difficulty in climbing stairs, raising from the chair, lifting objects over the head because of the shoulder girdle weakness. Examination, proximal weakness of the hip flexors, hip extensors, shoulder abductors, scapular winging can occur, calf hypertrophy may occur in some types, not in all the types. Contractures are very late. Subtypes, bedside patterns, sacroglycanopathies, similar to the Duchenne's muscular pattern, childhood onset possible, often very severe if you have sacroglycanopathy. Calpainopathy, that is the limb girdle muscular dystrophy 2A, common autosomal recessive, LGMD in many populations, scapular winging and pelvic weakness. Dysferrilinopathy, presence with distal calf weakness, Miyoshin phenotype, CK can be very high. Now, when do I diagnose LGMD? Should be suspected in a young person with progressive muscular weakness without facial involvement. So, young individual progressive muscular weakness, shoulder girdle, as well as the pelvic girdle, both are affected, and there is no facial involvement. If you have facial involvement, it comes under facioscapular. Facioscapulohumeral muscular dystrophy. Okay, this also adolescence and early adulthood. This also autosomal dominant, and the only difference between this and the other one is there is facial involvement here. But how does the facial weakness manifest? Patient cannot whistle. Like that he cannot. This moment he cannot put. Incomplete eye closure. Not able to tightly close the orbicularis oculi. Smile is usually whenever you smile, it is a curve. Whereas these people smile is transverse smile. Because these muscles are weak. They cannot pull the cheek this way. And it is a transverse smile. Difficulty in drinking through a straw. Give him a straw, ask him to drink the fruit juice, he will not be able to suck through the straw. Because the mouth, you cannot make it like a tube. To drink from the straw or to whistle, you have to make the lips like a tube. And that they are not able to do it. Pouting of the lip is absent. Cannot whistle, cannot drink from the straw, transverse smile, incomplete eye closure are features of facial weakness. Scapular weakness, scapular winging, difficulty in raising the arm above the shoulder, and scapular fixation by patient while lifting the arm. And humeral weakness, this is humeral means humor related muscle, biceps and triceps weakness. Other findings, asymmetric involvement is characteristic. Whereas till earlier, all are symmetric. In facioscapular, it is face, scapula, facioscapulohumeral. Humeral muscles means the biceps and triceps, the scapula muscle and the face muscles, and asymmetric involvement. And abdominal muscles also are involved. There is what is called the Beaver's sign. What is Beaver's sign? It is the upward movement of the umbilicus and attempted to sit up due to selective weakness of the upper abdominal muscles, classically seen in FSHD. So ask the patient to lie down and ask him to get up from the lying down position. Because the upper abdominal muscles are weak, while he is trying to get up, the umbilicus is pulled towards the sternum. That is the Beaver's sign. Leg involvement is later, particularly tibialis anterior, which is important from the dorsiflexion. Exam one-liner, asymmetric facial weakness with scapular winging and biceps and triceps wasting strongly suggests FSD. Okay, now myotonic dystrophy. Myotonic dystrophy, DM1, dystrophic muscle myotonia, DM1, young adulthood and variable, autosomal dominant, and then myotonia, delayed relaxation after hand grip. So ask the patient to give a hand grip. He presses all right, but is not able to relax immediately and loosen it. He keeps on holding the hand. That is delayed relaxation of the hand grip. Percussion myotonia, difficulty in releasing the hands. Then weakness, more distal, hand grip weakness, foot drop, and facial and neck involvement. So myotonias are generally distal, whereas DMD and other types are proximal. Hand grip weakness, difficulty to relax the hand grip, foot drop are already there. Characteristic faces, long thin faces, temporal wasting, and ptosis will be there. So this is a myotonic type of dystrophy. So this is the fourth type. First one is Disney-Becker type, Disney or Becker. Second one is the limb-girdle type. Third one is the facioscapulohumeral type. And fourth one is the myotonic dystrophy. In the myotonic dystrophy, adulthood, autosomal dominant, myotonia is the feature, and then they not able to relax the hand grip, typical weakness of the distal muscles, hand grip weakness is there, foot drop may be there, facial and neck involvement will be there, characteristic long thin face, temporal wasting, and ptosis. Most important part is cataract. These people will have very early cataract. It's always, I used to have one patient who came at around 24, 25 years and developed bilateral cataract. The ophthalmology people have asked him to undergo the operation. Then he came to me, sir, why I am having cataract at such a young age, 24 years. Then when we examined, it is a case of myotonic dystrophy, ultimately. This is called the Christmas tree cataract. What is the regular cataract? Regular cataract, there will be uniform dense opacity of the lens. In the Christmas tree cataract, what will happen? There will be patches of opacity and patches of normal lens will be there. This is called the patchy or Christmas tree cataract. Cardiac conduction defects are very common. Cardiomyopathy is not common. Cardiac conduction defects, insulin resistance, hypogonadism, infertility, frontal baldness in a young individual with myotonic weakness must consider myotonic dystrophy. And the next type is EDMD, Emery diffuse muscular dystrophy. Obviously, I told you E is early contracture. So contracture is the feature here. Early contractures, scapuloperoneal weakness, and cardiomyopathy is a feature. Childhood or adolescence, early contractures, elbow flexion. Patients will be like this because of the elbow contracture, elbows are flexed. Tender Achilles is tight. There will be toe walking. Neck extension is limited because contracture of the neck flexors. So you'll not be able to extend the neck completely. Weakness of the distribution, humeroperoneal. Humero means brachial muscle, the brachialis and the biceps, and peroneal is the anterior compartment of the leg, peroneal muscles. Later, generalized can be there. Conduction block may be there. Sudden cardiac death is a risk. Pacemaker often needed. Finally, distal myopathies, where nothing is there in the proximal part, only distal weakness will be there, hands and distal weakness, foot drop will be there, finger flexor weakness will be there, often adult onset, misdiagnosed as neuropathy, unless sensory sparing is noted. Now, I have to distinguish these four types. What are the four types? DMD, LGMD, FSHD, myotonic dystrophy. DMD is Duchene's type of muscular dystrophy. Duchenne and Becker, they don't differ. Only what is the big difference between Duchenne and Becker? Duchenne is early in onset, that is late in onset. Duchenne is fast progressing and Becker is slowly progressing. Both are autosomal diseases. Both are X-linked diseases. Okay. Now, Duchenne 2 to 5 years, LGMD, limb-girdle muscular dystrophy, teens and young adults, FSHD, facioscapulohumeral, face involvement, whistling, and then the difficulty to drink with the straw, and then horizontal smile. All these are because of the face weakness occurs in the teens. Myotonic dystrophy, young adults. Face involvement, not there in DMD, not there in LGMD. It is a feature in FSHD. It may be there in the myotonic dystrophy. Gower sign, very prominent in DMD. LGMD may occur, very uncommon in facioscapulo, not seen in myotonic dystrophy. Calf hypertrophy, pseudohypertrophy is there. This is because of the fat infiltration and also fibrosis of the muscle, not actually muscle tissue. And it is not there in the case of LGMD, not at all a feature of the FSHD and myotonic dystrophy. Progression, very rapid. By the time of second decade, they will end up in a wheelchair. Whereas LGMD is slowly progressive, FSHD is very slow, and myotonic dystrophy also is very slow. So myotonia, not a feature in all the three, except in this one. What is myotonia?
Relaxation.
Difficulty in relaxing. Okay. Muscle weakness is difficulty in contracting. Okay. Something like diastolic dysfunction. Systolic dysfunction is a dysfunction in the contraction of the heart. Diastolic dysfunction is the relaxation of the heart. Like that, myotonia is generally relaxation difficulty. Okay. So distribution. Cardiomyopathies are a feature in DMD, LGMD, they may be very less variable, FSHD less common, conduction defects are a feature in case of myotonic dystrophy. Distribution, proximal proximal, scapular and face, distal and symmetry. Now, I'm summarizing it. DMD, early onset, gower, pseudohypertrophy, wheelchair by teens. BMD, Becker's muscular dystrophy, DMD like, slow in onset, slow in progression, and they will be walking even after 15, 16 years. FSHD, facioscapulohumeral, facial weakness with scapular winging, asymmetry in the face, not able to whistle, not able to suck from the straw. There will be horizontal smile. All these are facial involvement. Myotonic dystrophy. Myotonia is a feature, distal weakness, early cataracts, particularly Christmas tree cataract, and then the cardiac conduction. EDMD is contractures, early and cardiac conduction defect. So these are all the teaching parts. Now let us look at the questions. Read that question.
4-year-old boy is brought with frequent falls and difficulty climbing stairs. Parents say he rises from the floor by climbing up his thighs. Examination shows calf enlargement in lumbar lobes. CK between toes. B. It's DMD.
What is the diagnosis? Why?
Patient early onset.
4-year-old boy, frequent falling, not able to climb stairs, raises from the floor using Gower strain. Examination, pseudohypertrophy is there, lumbar lordosis is there, CK is elevated. What else is required? But why it is not Becker? Late onset. It's a 4-year-old fellow. Why it is not spinal muscular atrophy? Spinal muscular atrophy is because of spinal cord disease. There is a muscular atrophy will be there. There is no business for the CK to be elevated. Spinal muscular atrophy is called SMA. SMA CK is normal. Why it is not limb girdle muscular atrophy? There is no shoulder anymore. Limb girdle means both pelvic girdle and pectoral girdle should be there. Other diagnostics also you should exclude. Why? Why they are not there? Okay. Early onset, Gower sign, calf pseudohypertrophy, very high CK. Next question you read. Why? Age is the teens, 19. And CK is not that much elevated. Still ambulatory, is able to walk, but progressive difficulty in running and climbing the stairs. Proximal muscle weakness is there. It is Becker's disease. Why it is not myotonic dystrophy? Myotonic dystrophy, difficulty in relaxation, hand grip problem will be there. All these things. And it is a late disease. And it occurs mostly in the upper limb muscles. This fellow is having lower limb injury. That too proximal muscle injury. Why it is not FSHD? No shoulder involvement, no face involvement. Why it is not dyspnea? Early age. And he is ambulant now. By the 19 he is still able to walk. By then they will be wheelchair bound. Okay. So this is Becker's. Similar to DMD, but later onset, slow progression. What I should look for? Cardiomyopathy I should. And very deep Q waves may be there for this fellow. Cardiomyopathy is usually a feature. No use. Read. Cannot whistle. Report difficulty in closing the eyes tightly. He has a scapular winging. Cannot lift arms above the shoulder. Weakness is asymmetry. Okay. On attempting flexion of the neck flexion, umbilicus moves forward, upward. What is that sign called? Beaver's sign. So this is a classical case of FSHD, facioscapulohumeral dystrophy. There is no involvement of the lower limb. There is involvement of the humerus muscles because of this one, and neck flexion is causing pulling of the abdominal weakness is there because the umbilicus is retracted upward, and then the difficulty in closing the eyes, difficulty in whistling, and scapular winging. All these suggest facioscapulohumeral muscular dystrophy, FSHD. Why it is not limb girdle? Limb girdle means pectoral pelvic. There is no lower limb here. Instead, face is inward. Okay. Becker's, why it is not Becker's? Becker will not have the face at all. Face.
No facial.
Why it is not emery-differus?
No contract.
There will be contractures. There is no contractures here. Okay. Because of the Achilles tendon relaxation contracture, toe walking will be there. That's also not described. So it is a case of FSHD. Then see, case histories are important for you to recollect what you have learned. By whatever we have learned in the theory, when we are applying to the cases, it becomes easier, isn't it? Difficulty in releasing hand grip after shaking hands, weakness of wrist and finger flexors, temporal wasting, early frontal baldness. He has a history of cataract surgery at 28 years. Means what? I told you one patient came for cataract, and it is a case of myotonic dystrophy of type 1. Why it is not FSHD? There is no face involvement. And there is a hand grip release is difficult. Cataracts are there. Okay. Limb girdle will have both pectoral and pelvic girdle. Becker will have progressive disease of the lower limbs mostly. There will be pseudo-hypertrophy may be there. So this is a case of, because of the cataract and all the presentation here, myotonic dystrophy should be suspected. Myotonia, distal weakness, cataract, typical phases. Now, let us look at that. A very classical feature is a young fellow, his elbows are like this, not able to fully extend because of contracture. Achilles tendon is tight, toe walking is there since childhood, progressive weakness of the shoulder muscles and lower limb muscles also. Both shoulder and lower limb both are affected. ECG shows conduction defect. So such a case is a case of emery-diffuse muscular dystrophy or EDMD, emery-diffuse muscular. Why not it is dyspnea? Very late compared to dyspnea. By 5 years it will be over. Most of it, and it's 14-year fellow. Why not it is limb girdle muscular dystrophy?
So,
There is myotonic features will not be there. Achilles tendon tightening and toe walking, difficulty in releasing the handshake, they won't be there. In the limb girdle dystrophy, and both pectoral and pelvic girdle. What is Charcot-Marie tooth?
neuropathy, familiar symptom,
Okay, that also is not fitting. So the answer is emery-diffuse muscular dystrophy. Early contractures, humeroperoneal weakness, cardiac conduction block. Next. 17-year-old girl, progressive difficulty in raising from the chair, climbing the stairs, involves a pelvic and shoulder girdle, no facial weakness, scapular winging is mild, CK is 6000, family history such as autosomal recessive pattern.
Face is not
limb girdle type of muscular dystrophy. Typical, 17 years. There is no face involvement, no FSHD. It is not myotonia because relaxation is not a problem. It's not the spinal muscular atrophy either. Now use. Reflexes are absent. Okay? Fasciculations are present.
Silence.
Means what? Anterior horn cell disease. Reflexes absent. Anterior horn disease. Fasciculations are present. The SMA, spinal muscular atrophy. It is not myomin muscular dystrophy. Element signs, normal CK. That's also another feature. CK is normal. If it is muscular dystrophy, we expect the CK to be very high. Now you see.
So, for examination, on the effects of Krishna Madhuri, CK, my days, muscular dystrophy, myotonic dystrophy, which is
40-year-old man, progressive foot drop. That is involvement of the peroneal nerve. Isn't it? Foot drop. 2 years. Sensory examination is normal. Reflexes are present. Mild distal wasting is there. CK is mildly elevated. Motor neuron disease, what do you get? Do you get foot drop in motor neuron disease? You don't get. Distal muscular dystrophy? Possible. But why foot drop? Foot drop should not be there, isn't it? CIDP is a chronic autoimmune polyneuropathy. That also does because there are no sensory nerves. Sensory is normal. So I'm left with the peroneal neuropathy or distal muscular dystrophy. So we have to now differentiate distal muscular dystrophy and peroneal neuropathy carefully. Since the sensory in examination is normal, if it is peroneal neuropathy, I expect some amount of sensory involvement also along with the foot drop. But sensory is normal. That's how you have to work out. That's why it is distal muscular dystrophy. So no sensory loss. Preserved reflexes. Okay. What is this?
progressive weakness, weakness is permanent.
Finger flexion weakness is very typical of inclusion body myocytes.
But in somebody process will be spared, no, sir? So it's probably
CK mildly elevated, no rash. If there is rash, what you have to consider? Dermatomyositis, you have to consider. So in IBM is the inclusion body myocyte. Early quadriceps weakness, elderly person, finger flexor. Age is 62 years. Muscular dystrophies won't occur at that age. So elderly presentation, finger flexion weakness, and quadriceps wasting is prominent. That is an inclusion body myositis. Okay, now you see. Enlarged calf muscles with proximal weakness. That means it is a pseudo-hypertrophy. What is the cause of pseudo-hypertrophy? They are asking. Fat and connective tissue infiltration. Not true hypertrophy, not edema due to inflammation, not glycogen storage disease. Okay? So these are the various questions also we have got. This PDF also we will circulate. With this we have completed neurology and myopathies and all that.